Welcome back to the Neurology 101 series here on the ProPA podcast. I'm Dr. G, and today we're exploring a fascinating condition that bridges both neuro and geriatrics: normal pressure hydrocephalus, or NPH. We touched on it in the last episode, but this one's high yield for exams and high impact in clinical practice. Let's dive in. Did you know that NPH is one of the few reversible causes of dementia? That's right. Early recognition and shunting can bring dramatic improvements in mobility, cognition, and continence. But it's often missed because symptoms look like other common neurodegenerative diseases. Let's look a little bit deeper at the kinder patho. What is normal pressure hydrocephalus? Well, NPH is a form of communicating hydrocephalus, where cerebrospinal fluid is not absorbed properly, leading to ventricular enlargement without a sustained increase in ICP. The enlarged ventricles stretch periventricular white matter, especially in the frontal lobes, causing gait instability, cognitive changes, and urinary incontinence. So, how do these patients typically present? Well, they have the classic triad. They are wet, wobbly, and wacky. Wet refers to urinary urgency or incontinence. Wobbly, gait disturbance, broad based, and a magnetic gait. And wacky, cognitive decline, executive dysfunction, and apathy. It is most common in adults greater than 60 years of age. Gait issues typically precede cognitive or urinary symptoms, and symptoms are progressive but can reverse with treatment. How do we diagnose NPH? Well, imaging is going to be our mainstay. An MRI or CT shows that ventricular enlargement or hydrocephalus. We may see disproportionate enlargement relative to cortical atrophy. We also want to consider the Evans index, which is greater than zero point 0.3, and this indicates enlarged ventricles. We can also do a high volume lumbar puncture, which can be both therapeutic and diagnostic. We might see temporary symptom improvement, and this will support our diagnosis. The LP opening pressure is typically normal, hence normal pressure hydrocephalus. How do we treat this condition? Well, we want to consider placing a ventricular peritoneal shunt or VP shunt. This is going to be our definitive treatment, and the greatest improvement is seen in gait, followed by continence. Cognitive improvements are more variable. We want to reassess after a trial tap. We want to remove somewhere between 30 to 50 mLs of CSF through an LP. If we see significant improvement in gait within 30 to 60 minutes, this indicates that the patient might be responsive to a shunt. Book med versus street med. So in the book, patient's going to present with the dementia, incontinence, and gait changes, and we're going to think NPH. Street med. We might have an 80-year-old man who started walking like a drunk, is forgetting things, and now wears Depends. CT shows huge ventricles. After a spinal tap, he walks more normally within an hour. This is your classic NPH. Shunt him and watch him improve. So, some quick clinical pearls. NPH mimics Parkinson's and Alzheimer's and even vascular dementia, suspected in older adults with progressive gait disturbance. An LP shows a normal pressure, but the ventricles are enlarged. Always consider NPH in new dementia cases with prominent gait issues. And early treatment equals better outcomes. All right, now it's time to test our knowledge. An elderly man presents with progressive gait disturbance, memory issues, and new onset urinary incontinence. MRI shows ventriculomegaly. What is the most likely diagnosis? Is it A, Parkinson disease, B, Alzheimer's disease, C, normal pressure hydrocephalus, or D, vascular dementia? If you said C, normal pressure hydrocephalus, you are correct. This is the classic triad of NPH, and ventriculomegaly is seen on the imaging, which seals the deal. What test is most helpful in predicting whether a patient with NPH will benefit from shunt placement? Is it A, an EEG, B, serial head CTs, C, high volume lumbar puncture, or D, a brain biopsy? If you said C, high volume lumbar puncture, you are correct. Remember, a trial LP is both diagnostic and predictive of response to VP shunting. Okay, so some final thoughts. NPH is a zebra that looks like a horse. Gait changes, dementia, and incontinence should always prompt you to rule it out. Why miss a treatable cause of dementia when you can make someone walk, think, and live better? In our next episode, we'll switch gears over to traumatic brain injury, or TBI, a leading cause of long-term disability in young adults. If this episode helped clear up a cloudy topic, drop us a review or text it to your study group. And as always, this is the Pro PA podcast, where future pros in medicine are made. See you soon.